All right, thank you. My name is Alexandra Stratton. I'm an orthopedic spine surgeon in Ottawa, Canada. I'd like to acknowledge my co-authors and to thank EUROSPINE for the opportunity to present. I have no disclosures. Over 450,000 lumbar fusion surgeries are performed annually in North America, and as we know, this rate has increased substantially over the last 20 to 25 years. Reoperation rate, for all reasons, comes in around 1 in 5 patients at 5 years. This accounts for over $50 billion in hospital costs alone for revisions. There's limited evidence available on patient-reported outcomes following primary versus revision lumbar fusion surgery or decompression surgery with or without fusion. The majority of the evidence shows that there's greater improvement in primary surgery. Patients undergoing revision by definition are older, have more comorbidities often, and numerous studies suggest that patients with multiple comorbidities have worse outcomes. No large studies have provided data where patients are matched based on comorbidities. Our objective was therefore to compare in a matched cohort patient-reported outcomes in patients undergoing primary versus revision lumbar fusion surgery. This was based on data collected from the Canadian Spinal Outcomes Research Network, which is a database across Canada with 14 contributing centers. The inclusion criteria were adult patients who are undergoing lumbar fusion with a minimum follow-up of 12 months. We excluded surgery for reasons other than degenerative. This was a retrospective analysis of prospectively collected data in the CSORN database. Patients were matched 1-to-1, primary and revision, based on using the following criteria: age, gender, BMI, diabetes, smoking status, and ASA score. We then assessed the difference between these groups on the following patient-reported outcomes: ODI, EQ5D, SF12, and VAS, back and leg pain. These charts here show the baseline demographics, and on the right you can see that once we controlled for, did the matching and controlled for the different demographics, there were no differences in any of them, including age and sex, which were previously different in the two groups, and we ended up with 696 patients in the primary group and the revision group. For the results, for ODI and EQ5D, in the after matching cohorts, ODI and EQ5D improvement was less in the revision group versus the primary group. Both groups improved at a year compared to their pre-op status. For VAS, back and leg pain, in the matched cohort, revision patients experienced less improvement in VAS, back and leg pain, revision compared to primary. However, both did improve. So for example, for leg pain, which is a common indication for lumbar fusion, decompression fusion, patients started at 8 out of 10 for pain and ended at 2 out of 10 for pain in the primary group and 4 out of 10 in the revision group. In conclusion, patients undergoing revision, decompression, and fusion surgery exhibited significant improvement in all their post-op PROMs at 1 year compared to their pre-op status. However, the revision cohort had less improvement in PROMs when compared to primary decompression and fusion cohort, even after matching. Patients undergoing revisions did meet the MCID cutoffs for all domains post-operatively. Patients undergoing revision, decompression, and fusion surgery can therefore expect significant clinical improvement. However, the magnitude of improvement is unlikely to be as pronounced as their index procedure. Previously reported risk factors for worse outcomes in this cohort cannot entirely explain the differences in patient-reported outcomes between primary and revision cohorts. Thank you.